Are you ready for me?
Yep, we're ready. I was just going to give people another minute to see. We had 9 signed
Okay.
up, so I was just going to wait one more minute,
Okay.
just to make
All right.
sure. We do have one person muted.
Okay.
Okay, we might as well get started. So again, here we have Dr. Andrew Heyman, and if you want to get going, that's great.
Great. Thanks. Thanks for attending tonight. I think it's Wayne, and this is a pretty interesting case. It represents what I typically see in my practice on a daily basis, and I think it goes to show both the value of the organizational model of the triads, but sometimes it also shows that you can capture someone and show that, as I've said, this patient is an extremist. But sometimes even the labs that the code draws doesn't exactly tell you what's wrong, and I'm going to show you a small additional set at the end to give you the punchline. But the report, I think, is very striking. And so this is a patient. She is a 34-year-old female who presented to my practice, and I've not seen her back. So this is just based on an initial consult as well as the result of her lab testing. Her main complaints are anxiety, fatigue, and abnormal menstrual bleeding. She's had quote-unquote hormonal abnormalities for the last several years, and she has not been able to regulate her hormones effectively using oral birth control pills. And so about a year ago in October, she was offered Nexplanon, which is an implantable progestin, which can stay in place for a number of years. Prior to that, about 18 months ago or so, she had been tried on Armour Thyroid, DHEA, topical progesterone cream, and vitamin D. More recently, after the implantation, she noticed that she's been having these cycles of very heavy bleeding for 3 to 4 weeks at a time, and these occur in about 6-week intervals. She is not in a relationship, and she works for her family, performing financial analysis in their family-owned company. So she's under a lot of stress. She works long hours, and she's been noticing over the last 6 months or so significant weight gain, and this is 50 pounds in 3 months, and that's despite going to the gym 5 times a week and consuming a very low carbohydrate diet. She's a calorie counter, and so she's been eating anywhere from 1,100 to 1,500 calories a day, and she's still been gaining weight despite being careful and exercising very routinely. This is one of the main issues that's quite distressing for her, and she thinks leading to her anxiety. She is admitting to episodes of panic attacks as well. That's very uncharacteristic for her. She's never really been a self-described anxious person, but this has been slowly building over the last year or two. She had been to a quote-unquote anti-aging specialist who thought that she had a hormonal imbalance, which is why she was tried on the aforementioned hormones. She's also reporting more recently some cognitive issues. So her memory has not been very good. She's been having some mental confusion, word-finding difficulties, and reporting headaches, but they don't seem to have a pattern, and they're certainly not tied to her menstrual cycle, which she really doesn't have one now, even though she has these bleeding episodes. She also reports some neuropathic symptoms, so paresthesias in her hands, and actually starting in the elbows, going down to the fingers. But it comes in waves. They're sort of either pins and needles, or they can even be ice pick sensations, and they started about 3 months ago. She also reports very poor sleep. So she only obtains about 6 hours per night. It's very difficult for her to fall asleep. She'll often stay awake. She says staring at the ceiling, laying in bed for hours, extremely tired, but not able to actually fall asleep. And when she does finally get to sleep, it's quite disrupted, and she's up several times during that 6-hour period. In terms of the weight gain, she describes that, as she says, I've always been fat, but over the last 6 months or so, this has been very distressing for her, that she's been gaining an inordinate amount of weight, which is outside of the bounds of reason with respect to her lifestyle choices. She knows that, she's been under a lot of stress, but she doesn't think, that alone should directly contribute to the weight gain. She does not have a lot of digestive issues per se, no air hunger, shortness of breath. She does have a history of asthma, as well as a history of some palpitations every few months. So bad, in fact, she went to the cardiologist, and they weren't able to determine what was occurring with her. She lives in a 9-year-old home, which does have a basement, but she denies any water infiltration. Her physical exam was normal and not really contributory. So in sum, this is a patient who has fatigue, anxiety, sleep-related issues, stress, hormonal imbalances, new onset headaches and neuropathy, as well as some cognitive decline. And this is a patient who's relatively typical for my practice, but certainly doesn't follow sort of the common storyline that we'll often see in regular practices. So I just saw this report earlier today, and I want to go through it because I think it really demonstrates some important points, and also the degree to which she's sick, especially for a 34-year-old young woman who otherwise, based on her lifestyle choices, should be healthy. In terms of her total predictive risk, summation of symptoms and lab scores, her first triad does rank highest at 630. Anything over 500 we know is significantly imbalanced, and this occurs across all 3 domains within the first triad. Close second is triad 2. So you can see she has those cognitive issues, and she has some other markers that raised her score for gut. She also tested moderate for triad 3. You can see on cardio, neurovascular, nothing on pulmonary. She only scored a 235 on triad 5, but it's ranked 4th. Although I think you'll see that she has quite a lot of problems here in this particular triad. And then there's really nothing in triad 4. But when you begin to kind of tease her apart and you look at her labs and symptoms through our overall predictive index, you can see that this is a young woman who's at very high risk across all of the domains. So she has accumulated a fair amount of metabolic imbalances, and this, of course, is very concerning to me as a practitioner, and you begin to question what's really going on with her. Clearly, while she's presenting with what appears to be hormonal imbalances and weight gain and fatigue, there's something else going on with her. And if you listen closely to her story, you begin to hear a theme that involves the nervous system in particular. The cognitive decline, the anxiety, the sleeplessness, the peripheral neuropathies, palpitations. So, sometimes you have to be really acutely aware and just be present and listen. But patients will tell you what's wrong with them. It would be easy to be distracted by what sounds like hormonal issues, but clearly she's got, other problems. In terms of the breakdown with regard to her specific lab markers, her cortisol actually measured normal at 17, Her DHEA was a little low at 135, and her sodium was well below normal. So, there are some issues here in terms of her spilling sodium, and so she's developing some electrolyte abnormalities, which I'll talk about later. In terms of her thyroid, her total T3 was suppressed. Her free T4 was at the lower limit of normal. So there are some issues here. Interestingly, a large report just came out by the Endocrine Society looking at the role of endocrine disruptors or persistent organic pollutants. And what they said is that because these chemicals often don't go through first-pass metabolism and they're not therefore deposited in the bloodstream, they're directly inputted into the tissue, they bind directly to hormone receptors. And so they bypass feedback loops, meaning that, for example, there's a variety of endocrine disruptors and chemicals that will bind directly to T4 and T3 and will cause a functional hypothyroidism, but the TSH will be normal. And so you can see someone who sometimes will have symptoms of thyroid issues or even low T4, T3, but a normal TSH. This just came out this week, and it's a pretty interesting read. In terms of her blood sugar and pancreas, not much going on, maybe a potassium that's a little bit low. But she does report postprandial fatigue, and that's why I think she scored higher for her pancreas, at least based on symptoms. In terms of her gut, she's mildly inflamed at 2.3. Not too bad, though, especially given how much weight that she's gained, and I'll talk about that as well when I give you the punchline. Her eosinophils were okay, maybe a little bit elevated. We know patients like this, at least from my perspective, can get quite histaminic and allergic. I'm surprised that it was only 2.8. I could see it even be higher than that. Her monocytes were 10.6, so she's ticking a little high as well, and her vitamin D is quite low. And this is quite normal in these sorts of patients. If we had measured her 125 vitamin D, I guarantee it would be very, very high. So she's not converting to the 25 hydroxy, and that's typical in patients like this. In terms of her immune system, she doesn't have a lot of abnormalities here that are measurable, at least in terms of standard lab markers. And knowing what I know about this patient, I'll explain why that is in terms of a CRP and some of these other lab values. In terms of brain, we can see that she has methylation issues and problems with detoxification. Her homocysteine is 13.3, so she's quite depleted, and this creates risk for toxicity globally as well as to the brain and the heart in particular with her elevated homocysteine. So she's got some real issues here in terms of her lower level folate and an elevated homocysteine. We didn't check an MTHFR on her, but I'd be wondering if she has a defect there as well. In terms of cardiovascular, not a lot going on here that I could see. Her blood pressure, when I measured, actually was okay. It's not reported here. Her pulse was 74, so it was a little elevated. The upper limit of acceptability is 76, especially in women. These patients who are inflamed in the way that she is and having the kinds of symptoms that she does, they tend to actually be hypoxic. And I'll talk about some of those labs as well, which is why typically their heart rate is higher. So I'm not surprised that it's ticking away at 74. In terms of her liver, she's a little anemic. For me, not surprising as well. And again, it sort of goes with her hypoxia. So you can see some metabolic disturbances there. White blood count was okay. Again, that's normal. For kidney function, you can see her B1 and creatinine actually are low, meaning that she's losing, she doesn't have a lot of muscle mass. And so she's got that sarcopenic obesity. So she's skinny fat, but she's really overweight. My guess is she just has very low muscle tone underneath. And you can see that she's not consuming enough protein anyway in the diet because her protein levels were low. And then in terms of her hormonal disturbances, remember she has Nexplanon, which is an implantable progestin. You can see her free testosterone was a bit above normal, but her total testosterone was okay. But her real problem is in her estrogen. So estradiol and estrone were very, very high. They were 3 or 4 times normal in both cases, despite the fact that she's not using any exogenous estrogen. You could maybe this is from the weight gain, potentially this is from an endocrine disruptor, but there's clearly a major hormonal imbalance going on with her, which doesn't really have to do with an implantable progestin. Not surprisingly, the progesterone itself is quite low because of the Nexplanon, and these labs in particular would explain, because of the estrogen dominance, that repeated building up of the uterus and then bleeding. So she's got real issues here with respect to her hormonal imbalance, and that really needs to be fixed. In terms of her symptom scales, she tested moderately high in most areas. Triad 1 ranked highest, Triad 3 second, Triad 2 third, and Triad 5 and 4 really didn't have a lot of symptoms here, but you can see how, she is mapping onto that estrogen and progesterone. And not surprisingly, that brain as well. So, this is a pretty classic or typical case for a patient like this. So if you notice, there's a lot of labs that are loading into Triad 1. The same is for Triad 2, and then Triad 5 for her hormonal imbalances. Some in Triad 4, and I would say that this actually will become a bigger issue once we really look at it. But it didn't test terribly high in the report, but knowing what I know about these patients, her toxicity level is something that will need to be addressed. And then we go through the alert lab summaries. I think you know all of this. So let me talk about what we did find. So I'm going to pull up the next set of labs on her, and these are probably ones that you haven't seen before. But this is an additional set that we run through Quest, and you can see her vasoactive intestinal peptide, which is a neuropeptide, was normal. Her C4A, which is a split complement product, was normal at 2165. This occurs when there's a systemic cytokine release due to some sort of biological exposure. This was normal for her, but her C3A level was quite high at 1098. So C3A is another split complement product. It elevates in the setting of specific cell membrane proteins that we see on bacterial infection. And so the bottom line is, when you see an elevated C3A, and you really have to do these through Quest, what it indicates is that this patient likely has Lyme disease. And so in further discussion with her, I had my nurse practitioner call her. She admitted to a number of tick bites, and so now we know why she's in such extremis. And it's because Lyme, as a clinical model, is really a neuroinflammatory problem. Basically, once we trigger what's called the innate immune system, and C3A is part of that, there are a certain group of patients where we see abnormalities in these unique innate immune markers, not CRP, not sed rate, not white blood count, but rather TGF-beta1, VEGF, VIP, melanocyte-stimulating hormone, as well as the C4A and C3A. I don't have any of those back yet, but it's clear to me that she has triggered her innate immune response. What happens then is, as the cytokine levels start rising, they directly impact brain tissue. And so we know the cytokines will injure the hypothalamus in particular, and create alterations in leptin receptors. So there's a relative leptin resistance that occurs in these patients, and they'll have rapid weight gain that's not responsive to lifestyle interventions, and that was her case. We also see abnormalities in other regulatory hormones like melanocyte-stimulating hormone. MSH is a master control hormone for all other hormones in the body. This is likely why we see an elevated estrogen in her. I don't think it's due to the Nexplanon. I think it's due to the MSH issues. Likely her MSH is low. We also see alterations in electrolytes. So typically we measure abnormalities in osmolality as well as antidiuretic hormone, which is likely responsible as well for her low sodium and some of her other issues, especially fatigue. What we then see in these patients when we scan their brain are key changes in certain areas like the thalamus and cerebellum, as well as the putamen. So I wouldn't be surprised if we'd see swelling in certain areas and dendritic pruning or shrinkage in others. So make no mistake, Lyme disease is a neuroinflammatory disease which creates brain-related changes. Due to those changes, we see these peripheral abnormalities, and they will cut across just about every bodily system. So when you really trace the variety of innate immune imbalances which weren't captured in the triad panel, they begin to articulate more deeply why she has so many symptoms in so many body areas. But the first layer, sort of the standard lab markers as organized by the triads, really call to arms, the issue of she's in a bad way and needs to be treated. And my experience has been these patients, while you can do the normal things in terms of following those labs and offering supportive therapy, she's not someone that's going to get better unless you directly address treating the Lyme as well as rebalancing her innate immune markers too. So over time, we'll likely see the C3A level come down, and that would have to be with some very specific therapy. Now, what did the system itself recommend as a result of these triad imbalances? And even I had mentioned she has an elevated pulse. Well, that's usually due to a lower VEGF, which is vascular endothelial growth factor, which controls blood flow through the capillaries. So these patients typically are quite hypoxic. They'll have a VO2 max below 30 and an elevated pulmonary arterial systolic pressure, meaning that they're developing pulmonary hypertension as a result of the low VEGF and the high C3A. So I typically measure that in these patients, and they're often short of breath. They report air hunger. They have an elevated heart rate, and they're at risk for cardiac disease as a result, ultimately, and one consequence of that is arrhythmia. In addition, her eosinophils were a little bit high. Sometimes I see them even higher. And so these patients will typically be quite histaminic. They often have mast cell problems, so they're degranulating all the time. And that excess histamine production will lead to arrhythmias, brain fog, weight gain, fluid retention. So these patients can be a real mess from the brain on down. So in terms of the typical treatments for her, we can see how, yes, she needs some help with her adrenals, with DHEA, as well as some calcium replacement because she's, quite frankly, acidic. She likely does have some candida overgrowth. She needs some support for her progesterone. Her vitamin D levels are low, although that typically corrects on its own as you get these people better. So what happens is there's some abnormalities at the vitamin D receptor as a result of this chronic inflammation, and they don't convert very well from the 125 to the 25. So they'll often have very low vitamin D, which is exactly what she had. There were some clearly suggestions to eliminate estrogen, which she really needs. That's kind of critical for her. She also needs methyl support with the Folapro. Lots of magnesium. I think that would be an excellent choice for her. Some melatonin for sleep at night. Some fiber, fish oil, and some calming still point. The fish oil is an interesting selection. I would say these patients typically have quite a lot of lipid abnormalities. This is sort of the target of injury of the kind of inflammation that they have with innate immune activation. We measure that in our patients. We do a special lab that we send to Johns Hopkins, and we do a full review of all of the structural and functional lipids of the individual. It's a red blood cell cell membrane analysis, and so we can see quite a lot of damage to these patients with their lipid status, which means that not only do their cell membranes not work, but the inner leaflets, meaning what surrounds the mitochondria, are also injured too. So they have problems producing ATP on top of being hypoxic at the tissue level. And in addition to that, of course, the structural lipids are very important for myelin. And so this is one of the reasons why we see those brain-related changes, because it's a nervous system injury. Make no mistake, Lyme causes a brain injury, and you can see that globally with the special MRIs that we order called NeuroQuant. But you can also see it at the cellular and even subcellular level with our lipid testing. And so fish oil becomes an important part of the story, but we use other lipids even more aggressively, basically phosphatidylcholine, omega-6s as much as omega-3s, butyrate, which is a short-chain fatty acid, as well as structural lipids like octacosanol and prometol to help rebuild the cell membrane. Oftentimes, too, these patients have not been feeling well, and they'll usually reach for fish oil. And interestingly, we'll see that their cell membranes are too chock full of omega-3s, and we have to give them a better balanced oil, usually with more either evening primrose oil or borage oil, something that has healthy omega-6s in it. So this would be a good place to begin with her to start balancing those issues across her triads, especially triad 1, 2, and 5, to help sort of eliminate or burn off excess estrogens, rebalance triad 1, get her gut working again with a probiotic and a multi-mineral and vitamin. But she's going to need deeper work too, and I think you could see that when you saw all of those red markers for her vitality index scores. And so I think the triad system really did its job. And we see this all the time in my Lyme patients because they're so incredibly sick. But you do have to go to the next level. And I think with this initial set of treatments, you can start getting her feeling a little bit better, but there's a whole lot of other work that you're going to need to do to correct this individual. And the kicker, of course, was the high C3A, which kind of clinched it for me, and it made sense with respect to her cognitive decline, anxiety, sleeplessness, palpitations, paresthesias, rapid weight gain. Those are all classic symptoms of Lyme. Lyme, regardless of the textbook, is not really commonly a joint-related issue. It's more a neurologic one. And so she really fits the picture. And the peripheral hormonal abnormalities are really just reflective of the brain-related changes. So we see a lot of hormonal imbalances in these patients too, but that's the epiphenomenon. That's secondary to this patient in particular. So, once again, I think the triad system really helps to organize thinking and point in a certain pathway, but obviously you would need to, either collect more labs if you saw a report like this, or like what we did, we ordered an additional set at the time of the first visit, knowing that she symptomatically fit a pattern of someone who's had some sort of biotoxic exposure. So I'll stop there if there are any questions. I know that was sort of rapid fire, and this is a very sick patient, maybe outside the comfort zone of some of the listeners, but I'm happy to answer some questions because this is a patient who would need some real aggressive care.
Thanks, Dr. Heyman. I'm going to unmute everybody so they can talk. And I think, Wayne, you are muted. You have self-muted. So even though I unmute you, let's see. I think you're still muted. Okay. Oh, no, now you're good. Okay, so we have Lisa Larson and Wayne Furr. So we're open for questions now, if you'd like to go ahead. And you can just ask. You don't have to raise your hand unless you can't. Hopefully you can hear us. That's the other big question. I saw, Wayne, you had your hand up earlier.
Oh, no, I was unmuting. I had a little yappy dog. I didn't want to bother things. I'm a gynecologist, so I'm thinking in terms of what directed toward the Lyme disease aspect of it.
I couldn't hear the question. Could you say that one more time, or hopefully you're still there?
Yeah, what directed toward the Lyme disease diagnosis? Being a gynecologist, I don't make that diagnosis very much. So, in utilizing the metabolic code, what directs you to that particular Lyme disease aspect, the C3. Did you hear me?
Yeah. Yeah, I think your question is what triggered that possibility. Is that what you're asking?
Yes.
Why did Dr. Heyman go ahead and have that test done for this patient? Andy, are you there, Dr. Heyman? You there? Okay, there we go. You were muted. Okay.
Okay.
You heard that question?
Yeah, I did. So it was the elevated C3A. That's relatively specific to a bacterial exposure, and even more specific to certain kinds of bacteria like Lyme. So when it's elevated, especially around here in Northern Virginia, where we have the highest rates of Lyme in the country now, the pretest probability is quite high that this is a Lyme infection. We'll do our due diligence. We do have access to newer testing for Lyme. We've been participating in a research study with George Mason University, collecting data on a novel Lyme test called NanoTrap. This is basically a nanofilter that's able to collect very specific compounds that are of the sort of nano size. And so outer surface protein A is the marker that we've been targeting because it's a highly conserved protein on the outer coating of the Borrelia. And the test is proving to be highly sensitive and specific. In an untreated population, probably 95% or above. In untreated, we're not really sure how good the test is in a treated population. All of this started several years ago because of the recognition that Lyme was clearly an epidemic in Virginia in particular. And so the state Congress liberated funds to George Mason to develop a new technology. My guess is, we'll run a NanoTrap on her, and most likely she'll be positive. But just with a high C3A alone and the symptom clustering that she has with her patients, or the symptom clustering that she has in her presentation, it's all relatively diagnostic. Just like all of us, when you see something many times, you sort of become familiar with the patterns, and the C3A, as well as sort of the degree of abnormalities in her more standard labs, pretty much clinches it for me. But we'll run a NanoTrap. We also just published a study on brain-related changes due to Lyme, and they're relatively characteristic. So we'll probably get a neuroquant MRI as well. But one of the things that I've been fooled by over time with these patients is the degree of sort of what are perceived hormonal abnormalities, and not understanding that so much of that is being driven by hypothalamic changes. But now I know what I'm looking at, and I don't get so upset about it. But, when you look at someone like her and you see these lab values and the degree of symptoms, she's someone who clearly has some real issues.
Thanks.
Great. Any other questions? And I think Lisa joined us late. So just for your information, Lisa, we have recorded the session, and we're going to post this on metaboliccode.com. So if you want to hear the entire session, you can. I think somebody, let's see, there's a question here. Oh, she said thank you. Okay.